So, what initially inspired you to focus your research on sex differences in the brain and neurological disease?
I wanted to focus my research on things that I knew were clinically relevant to the population as opposed to some molecule in the lab that may or may not be relevant. And to that end, I look for things that are clearly true, but we don't know why, because you might be able to figure it out and turn it into treatment. So things that are clearly true are the fact that 3/4 of MS patients are women, and that for Alzheimer's disease, it's 2/3 to 3/4 that are women. So I was just saying there must be a reason, and if we can figure out why, maybe we could turn that into a treatment.
Thank you, Dr. Voskuhl, for joining me today on the podcast. I'm really excited about your work, the product that you're working on and sharing with women, and all the research behind what you've been doing as well.
Well, thank you for having me.
So, what initially inspired you to focus your research on sex differences in the brain and neurological disease?
I wanted to focus my research on things that I knew were clinically relevant to the population as opposed to some molecule in the lab that may or may not be relevant. And to that end, I look for things that are clearly true, but we don't know why, because you might be able to figure it out and turn it into treatment. So things that are clearly true are the fact that 3/4 of MS patients are women, and that for Alzheimer's disease, it's 2/3 to 3/4 that are women. So I was just saying there must be a reason, and if we can figure out why, maybe we could turn that into a treatment.
Okay, so the fact that women are driving these neurological diseases in the long run is part of the reason why you decided that would be the focus of your research?
Absolutely.
So can you explain the connection between estrogen and brain health, especially for midlife women?
So estrogens are known to be neuroprotective. They've been known to be for many, many decades. And the other thing that's known in these diseases, that those are basic science research in the labs. What's been shown in these diseases is something very interesting. First, starting with women with MS, and then starting with healthy women with menopause. And so what I found, and what was known forever actually, was that I see patients as well as run a lab. And so what the field always knew was that pregnancy is very good for women with MS. It not only reduces the inflammatory lesions in the brain, but it also causes them to have less disability in the long run if they've been pregnant several times. So that implies something for neuroprotection. So thinking the immune system as well as the brain, something really good is going on in pregnancy. And lo and behold, estrogens are very high during pregnancy. What happens when, and a specific one, which we'll talk about later, is unique to pregnancy, it's called estriol. But estrogens, by and large, are very high during pregnancy. Now, MS patients do great. Postpartum is bad. These hormones drop abruptly, and they go through relapses and disabilities. The other thing that's known is that when MS women go through menopause, their disabilities worsen. And so you've got a situation where estrogens are high, things are great. When estrogens are low, things are bad. So that was just really just logic tree for me. So then I started thinking about, well, gosh, what about healthy women when they lose their estrogen? Could that be bad? And sure enough, it's very bad. Bad in what sense? It's bad in the sense that they have cognitive domain-specific problems. That means they have problems with verbal memory, concentration. They'll read something but have difficulty retaining it. They'll lose their train of thought when they're talking, and then sometimes they get it back, but it's embarrassing. So these issues that they have, again, they're very, in a sense, they're not easy to recognize that much on the outside, but they make the women feel very uncomfortable and undermines their confidence, especially if they're lawyers, they're teachers, they're doing podcasts like you. They have to think on their feet. They have to talk. It also undermines them in social situations when they're at a dinner, they're given a talk, somebody interrupts them, they can't remember what they were saying momentarily. It's a pause. They usually get it back, sometimes not. So this is a problem. What it's not is it's not they have decreased IQ. It's not they're just as smart as they ever were. That's important to recognize. They're cognitive domain specific. That's probably one of the reasons it's been missed. Now, people have said that they just have hot flashes and they can't sleep. That's perimenopause, and yes, that's true. But hot flashes go away after 3 to 5 years. They're going to be menopausal for a third to half their life. They're not going to get the estrogen back just because perimenopause and hot flashes go away. So the problem is these cognitive issues also don't just go away. Now, sure, having a good night's sleep helps them temporarily, but it's more than that. And to finish, the reason it's more than that is when you look at brain MRIs on women who've been menopausal and untreated with any estrogen for a long period of time, a decade or more compared to a short period of time. They have atrophy and connectivity is what it's called. These certain areas of the brain, it's called hippocampus and frontal cortex. That's a detail, but there's certain regions that have problems on MRI. And so it's not just that they say they can't remember something. It's structural and it's functional going on MRI. Again, it's not the whole brain because it's not global anything. And that's, again, I think why it's been missed.
Yeah. And I mean, I know so many women that I talk with, the brain fog is just, it can be debilitating and it makes you feel like you need to be studied and tested for dementia or Alzheimer's. You know, I remember so many times I would be sitting and thinking, and it's like, words are hard. What is this word? And I would look at something and I know what it is. And it's almost like, did I have a stroke last night that I didn't know about? And it can be really crazy making and scary for a lot of women who don't recognize that it's a hormone related issue.
Yeah. And I think the scariness is very true. We can get into a deeper dive on that, but you're absolutely right. It's scary. And the reason is because, as I said before, Alzheimer's disease is 3/4 women. It's even 2/3 women. If you correct for age, that women live a few years longer, it's still there. And so many of these women actually have a family history of Alzheimer's disease in their family. They see every memory ward in a nursing home is filled with women. And so they've seen this and they know exactly what it is. It's very scary. Now, what I'm saying is that these things that happen, these cognitive issues that happen during menopause, during health, are they or are they not related to, and you know what I'm implying is, could it be related to Alzheimer's? I'll say right now, I don't know, but I am worried too. And the reason I'm worried is because Alzheimer's is primarily women. And we know by then it's really too late to fix things, which you have full-on Alzheimer's disease. So all of the trials and all the research and the big pharma, it's all fine. They all focus on the 10 years prior to Alzheimer's disease. That's called mild cognitive impairment. Mm-hmm. Well, what's 10 years prior to mild cognitive impairment? It's women with cognitive issues.
Yeah.
And the problem is we won't know causality. Yes, it predates it, it precedes it. Does it cause it? I'm a scientist, so not necessarily. I will say it's logical. But, and especially since those same areas are affected in menopausal women with cognitive issues, as are affected in Alzheimer's, the hippocampus, namely. That's scary. But I will say we will never know if cognitive problems in menopausal women lead to mild cognitive impairment for 10 years and then lead to Alzheimer's disease. We'll never know until we go in with an intervention to treat it and see if it works. Right now, there's no treatment until now. We're going to talk about that, but there's been no treatment of HRT targeting cognitive issues of menopause. There's none to try to fix it. We'll never know until we go in and fix those cognitive symptoms that they have, that we're all aware of in the short term, in the years that occur early in the 50s and 60s. We'll never know whether that prevents mild cognitive impairment and Alzheimer's disease until we go in with the treatment to stop those and see if it prevented or delayed Alzheimer's.
So you touched on the form of estrogen, estriol, and you talked about how we're going to get into that. And I think now is a good time to start talking about Cleopatra Rx. I've done some research and I had a conversation with somebody from your company about how it works and what's different about it. But what sparked the creation of it, and how did your research itself inform this decision to develop it?
What sparked it was this knowledge that pregnancy was so good for MS and it was so good for their brain in multiple sclerosis women. And so I said, well, what is it about pregnancy this is different? And there were a lot of things, and we went through them one by one in the lab. We said, okay, let's change this, let's change this, let's change this. And the estriol is the estrogen that's unique to pregnancy. It's not the same as estradiol. That's one of the major misconceptions that are out there. Estrogens are all alike. They are not all alike. It's an umbrella term. Estrogen is an umbrella term. There are many types of estrogens. And the two I'm going to talk about mostly are estradiol, which is the gold standard. It's in the estradiol patch. It's what's in HRT commonly. It's what was in the old HRT studies from 30 years ago that's gotten all the bad publicity, and rightly so, of breast cancer and so forth. Estradiol is not the same as estriol. Estriol is not there normally in women that are not pregnant. When they're pregnant, it starts and it goes higher, higher, higher. And sure enough, it goes very high in that last half of pregnancy when these MS women are very protected. Now, the reason I really liked estriol not only was because it was the estrogen type that was associated with pregnancy related protection in MS. The other reason I love estriol actually over estradiol is because there's a fear of estradiol. Mm-hmm. Estradiol patch is used commonly. It's FDA approved for hot flashes. That's it. It's also for osteoporosis. but it's used for hot flashes and even for osteoporosis for a short period of time at the lowest dose possible. 3 to 5 years, lowest dose possible for hot flashes. Why is that? Because it is the estrogen, estradiol, not estriol, estradiol, that binds strongly to a receptor in the breast associated with breast cancer. That's very scary. Breast cancer is one out of 10 women, even without a family history. And so that's why GYNs generally limit the number of years and the dose that you can have of estradiol. And as a neurologist, I'm saying this is a long-term problem for us with neurodegeneration. This is not a fast thing. It's not like hot flashes. It's not like it's going to go away. So we'll never be able to treat with estradiol to prevent long-term brain problems. That's not ever going to happen. So I focused on this estriol, which is the estrogen of pregnancy. And I used a dose that had been used in Europe for hot flashes for 40 years and been shown to be safe. And doing that, it was important because that estriol is thought as a weak estrogen. That's the name. It's the safest of the estrogen, but it's the weakest of the estrogens. Weak for what? It's weak for the estrogen receptor in breast. It's called estrogen receptor alpha. It's just a name. It was called alpha. Estriol is weak for alpha, estrogen receptor alpha. That's a good thing because we don't want to stimulate alpha in the breast. That tamoxifen blocks that as a treatment for breast cancer. So you block all estrogen receptor alpha binding during breast cancer in patients. When estriol binds to cause brain protection is estrogen receptor beta. So the beauty of this, we have an estrogen receptor in the brain that we can target specifically to get neural protection, brain protection, while binding only very weakly to the estrogen receptor in the breast that people are so afraid of. That's the beauty of it. We have a window.
Wow, that's fascinating. And I went to pharmacy school. I have a pharmacy background, so I'm aware of estradiol and the different forms of estrogen. And you're right, they don't talk about it when you learn about the forms of estrogen in school. I've even heard in the training and the reading I've done of estrogen products that estriol is weaker and less effective. But what you're saying makes so much sense. And it's a wonder why it's been available for 40 years in Europe and used for 40 years in Europe and not in the United States.
It is available it's known to be safe. It's also called the safest of the estrogens. And it's because it's thought to bind ER alpha weakly. That's exactly why. And it's known to help hot flashes. It's not as strong as estradiol for hot flashes, but you can increase the dose a little bit and it's still safe and you can get this effect on hot flashes. But no, if that's your primary concern, you're just having hot flashes, is just getting them every day, every night, and you're just totally miserable, then maybe that's your priority. But some people have them just every few times a week and they have some hot flashes, but that's not, and they also are having cognitive problems that they're worried about. And they also worry about getting breast cancer. So again, these things are tailored to somebody's main problem or not.
Yeah. And you hear all over social media that even though estrogen is good for the brain, there's no indication, there's no guideline that says estrogen should be used for cognitive impairment or any kind of brain fog issues. And so people aren't taking it or aren't being prescribed it because of the whole hierarchy of FDA approval and structured guidelines.
That's right. The reason all those things say that is because what are they talking about? They're talking about estradiol. And estradiol has not and probably never will be looked at for that. In the old HRT studies where it showed a predisposed to breast cancer, for example, and they say it's been overblown. It may be, but there's somewhere in between. There's the common ground. That's the truth. You know that. It could be overblown, it could be underblown, but it does because it's associated with breast cancer. And so the problem is when they say these statements that it shouldn't be used for cognition, they're talking about estradiol. And a trial has not been set up and designed to improve cognition, especially domain specific problems of menopause. That's not been done. In those old studies 30 years ago, they said, were they demented more or less? It wasn't designed for this. It was designed for hot flashes, where you basically treat for 3 months and see if it works. And then they say dementia. They don't say whether first of all, it's end-stage dementia. They're 75 years old. They don't say whether it's vascular dementia, Alzheimer's dementia, a mixed dementia. It's crazy just looking back at that data and trying to make any conclusions about it. The way to do this is to do a trial where you use exactly a particular estrogen tight dose timing, and the outcome measure should be cognitive domain specific problems. And if you wanted to do MRIs, which they didn't even look at in the older studies, if you did them at all, clearly it would be not the whole brain. It would be looking at these regions that are known to be affected in menopausal women with cognitive issues. That's how you would do the study. So yeah, there isn't any data showing that that's the case because it's not been done. And it actually can never be done, in my opinion, in estradiol. I think it's too scary to do it.
Okay. So if I'm following down the path, you're researching MS, and you're finding that pregnant women, their symptoms in MS are more mitigated and you're finding the correlation of higher levels of estriol in the body. And so then what caused you to recognize there was a cognition change in using estriol as well?
That's a great question. Yeah. So when we did the MS trials, we first asked whether it reduces brain inflammation, relapses, and the inflammatory lesions. That was the question everybody asks you when they start to develop a drug in MS, right? And so that's what we did. And we got this interesting side effect was actually, we did a standard test to follow how these MS women were doing. It actually improved cognition. And I'm like, what? And it was just put in there as a standard thing you do in MS patients, right? Their walking speed, their cognitive testing. That's what people do. And I was so surprised because it wasn't that it decreased. It wasn't that it slowed the rate they were getting worse. It made them get better. Now that's different. It's not just an anti-inflammatory effect of preventing damage. That starts to speak to growing more synapses and more connections where you can actually improve. It's called synaptic plasticity. Synapses are the connection between the nerves that make the electrical activity go through. So when you get improvement, it really makes you start thinking about that improvement. So we did it in one trial. They said, well, it could have been a placebo effect, even though the reason it was. Then we did this placebo-controlled trial where they were tested just as many times, the same times. They were blinded. They didn't know the treatment. And sure enough, the estriol treated had improved cognition at 12 months compared to those that got placebo. The second thing that we did MRIs of their brain about every 6 months. And we showed that at 12 months, we had reduced the cerebral cortex atrophy. So it's that layer of the brain on the outside that's involved in cognitive speed and processing. Sure enough, that layer there was less atrophy in the MS patient. They have atrophy ongoing because they have a disease. And they had less atrophy of that area when they were on estriol as compared to placebo. And it was, again, at 12 months. The third paper that we had was we looked at a blood biomarker called serum neurofilament light chain. That's a detail. But it's a biomarker for neurodegeneration in a variety of situations like aging, Alzheimer's, MS. And we found that was also decreased with estriol treatment as compared to placebo treatment. So we got some amazing data in the MS women showing that we have clinical response. They have improved cognition. They have a reduced regional atrophy, and they have a reduced biomarker for neurodegeneration in the blood. Because of this, and because it's got a specific type dose timing of estriol, as actually a specific type dose timing of progesterone that you take with it, I have patents. They're not mine. They belong to UCLA. I work for UCLA. So they belong to UCLA, and they've been licensed by a company that we may talk about later. It's called Cleopatra Rx. But anyway, the point is UCLA has patents that I'm the inventor on for this type dose timing of estriol, type dose timing of progesterone, and the protocol to have neuroprotection in women in actually neurodegenerative diseases, including menopausal women with cognitive issues.
Okay, so your studies in MS then led you to find this estriol was beneficial for them, and then you decided, let's try this in women, menopausal women that may not even have MS, but you're finding a benefit for them as well.
And the first thing we did, we had a paper in Nature Communications, but we went back to the mouse. So we said, let's get a menopausal model. And we had a model that's what I do. I go from clinic to the lab to bench to bedside. I go back and forth. So I said, before we go to menopausal women, let's do the mouse model for menopause. And we showed that there was sure enough, it was really interesting. There was an age by loss of hormone effect. So what I mean by that is these mice, they could lose estrogen. It wasn't really that bad. They could actually get to midlife, and it wasn't that bad. That bad, I'm meaning on their cognition, on their brain atrophy, and on the pathology in those areas. But when you combine both getting to midlife aging and loss of estrogen through ovarectomy, taking the ovaries out so they have loss of estrogen, when you combine both midlife aging with loss of estrogen, that was the combination that was so bad. It caused these mice, they're a model of this. It caused them to have poor cognition on testing. It caused them to have atrophy of the hippocampus, like I talked about before. And it caused them to have pathology, neuroinflammation, neurodegeneration, synaptic loss of those regions of the brain that were undergoing atrophy. So now we knew that we had a model and we could go in and test. So we then tested them. And we tested estriol, which is the estrogen of pregnancy because it binds ER beta. And we tested a pure ER beta ligand, just that. We even knocked out ER beta receptor out of different cells in the brain to show which cell in the brain it was working on. And we showed that. It's called an astrocyte, which is another story, which is the same story, but it's just a detail. So bottom line is we identified the receptor and the cell in the brain that it was working on so that we in this model of menopause. So then now, as you know, going to women that are menopausal and we're giving them this type dose timing of estrogen, type dose timing of progesterone. Again, known to be safe for 40 years in Europe. Do no harm. There we are. It's safe. And as you would expect, it's inexpensive because it's widely available. Not FDA approved because no company is going to do something that cheap, develop a drug that cheap. We've been monitoring them and we check their cognition at month 12, at month 0, month 12. Every year we check their cognition by a questionnaire I created that's specific for cognitive issues of menopause. So it's not like this Alzheimer's cognitive thing. They're not going to have that. And that's good. I don't want them to have that. We've got a questionnaire that's focused on verbal memory, concentration, retention, train of thought. You see what I mean? And so we're using those to ask, how did they do when they're on this treatment? At 12 months, of course, because we've seen significant results at 12 months. That's the key. It's not going to be fast. Hot flashes will be helped in 3 to 4 months. Actually, some of the other things like vaginal dryness and urinary incontinence, that'll be helped in about 4 to 6 months. But it will take, I still say, as a neuroscientist, 12 months to see this effect on cognitive improvement based on all the publications we have.
I'm fascinated. I'm a little nerding out on this. Like this is so.
It's because you're a pharmacist.
maybe that's what it is. I just feel like this is a hidden gem that a lot of people don't recognize could be really beneficial for women. So we've talked a little bit about the fact that it's estriol versus estradiol and its impact on the brain and body. And I was going to ask you a question about that. But what I'm really interested in now is, so you offer this product through Cleopatra Rx for women who are menopausal, and it helps with cognition, but then it also, after a few months, can help with all the other symptoms of menopause?
It does. It's not as strong. If you have just terrible hot flashes, you probably should take the patch for a few years. They're going to take you off of it after a while. But actually, if you have the general garden variety hot flashes, they're not that hard to fix. This has been used in Europe for 40 years, 4 hot flashes approved by the EMA for hot flashes 40 years ago. So it can do that. Yeah. So I will say that my specific type dose timing of the estrogen and the type dose timing of the progesterone to go with it, it's a little bit complicated. That's why there's a patent. That UCLA has a patent. And it's also hard for these women to remember. And so what we did I said the company, not me, what the company did, they made it into a blister pack for menopausal women. So most of us know from taking birth control pills, they're changing. It's actually norethindrone. It's a form of estradiol. It's a progesterone. Anyway, it's a detail of what those hormones are for birth control. Mm-hmm. But they are changing them from week to week. And there's a reason they do that. So what we did with Pearl Pack by Cleopatra Rx, we made a blister pack that does the same thing. It can change it from week to week the way that I think is most relevant from all my research that's been published and patented. It will be the most optimal for cognitive health. It's hard for them to remember that bottle here, nobody follows you. That won't work in these women. I can just tell you it won't. They'll mix up morning versus night, which one they're supposed to take. And when you don't take it, we also show that blood levels correlate with the cognitive improvement. You've got to be compliant. It's got to be easy. It's got to be intuitive. And so we make the blister pack where it's AM, PM. It tells them what to take. So
that's really smart.
That's the Pearl Pack, Cleopatra and the pearls. The pearls are in the pack.
Yeah, that's really smart because you're right. Vast majority of the women that are my age going into perimenopause have been on a birth control pill of some sort. And so it's a very familiar dosing. And, even somebody who I set alarms and I know the importance of compliance. I still forget to change a patch twice a week because it's not every other day. It's 2 random days in the middle of the week. And sometimes I'll leave the one on when I put the other one on accident because I forget to take it off. And even just taking something at night from a bottle can be hard to remember. And then you've got the supplements in and you add in life and how busy life is. We're the first person to drop our own health in the family, typically. So that's really smart. So if it's a pearl pack and it's a defined system for the month, are there different doses that are available, or is it one standard dose?
So that's the other beauty of what we do at Cleopatra Rx. We're not just a pill market, or where they push pills out. It's all one size fits all. That's just not the way that it is. Women differ with respect to how bad their hot flashes are. They differ with respect to how much risk you would take for breast or not. They differ in certain ways, and in a lot of ways, actually. So it's not a one size fits all at all. It's just not. So we start people on a particular dose, and that can even be one of two, depending on certain things. And it's a protocol that I devised, and we have a national nurses network and doctor network that does this protocol. We have compounding pharmacies. There aren't just Tom, Dick, and Harry's pharmacy from around the corner with different pills and who knows what they do. And sometimes they, heaven forbid, even mix up estradiol and estriol, which is completely terrible because it's not a dose equivalent, the number of milligrams at all. And so I was very worried about these things getting mixed up because I'd seen estradiol and estriol get mixed up in pharmacies. And that's scary to me. I find it scary to just give these women these things and not follow up with them on safety and efficacy. And so what Cleopatra Rx has done is, again, developed a national protocol with 2 national pharmacies licensed in all 50 states, an East Coast one and a West Coast one for better shipping locally, and also a doctor and a nursing network that follows them. It says, hey, how are you doing? And do we need to do a dose adjustment? Do we need to go up with this, down with this? We change it, or we can change how the Pro Pack is loaded based on those discussions with the nurses and the patients, one-on-one about how they are doing. And we've had to do some dose adjustments actually within the first 1 to 3 months. Sometimes it's tweaked, sometimes it's not. And I'm telling you, once they're on at 3 months, they're on and they never want to stop. Our retention rates are dramatic. People love it.
Oh, wow. So,
but they need that tweaking sometimes in the beginning just to see how do we need to change it a little bit. That's important. You don't just send somebody on their way and never talk to them again, you know?
Yeah. Yeah.
They're so busy and they barely make a distinction between estriol and estradiol. And then they're not even thinking about the brain health. They're not. I want to say one more thing about the brain in menopause. This is something that's really important. It's one of the big picture things. So it's been known in the literature, in the scientific literature, that 70% of women have cognitive issues of menopause. And actually, the UCLA Comprehensive Menopause Program that I'm the faculty neurologist for, the UCLA Comprehensive Menopause Program, we did our own surveys. And we showed that 70% of women said they have cognitive issues, and yet it's ignored. And on top of the 100% who was worried about them, about Alzheimer's, 70% are having them, and they're not even asked. So, you know, when they try to manage doses and do dose changes, they're not even considering the brain.
Yeah. No, I mean, you don't. And it's not an indication for hormone therapy replacement. Right. So it's just, you know, and doctors, I feel like, even for my own health experience, I had to go through a myriad of different care providers to find one who even was willing to give hormones. And so to have that layered upon just having to keep up with all the research and data, it's really hard. It's hard for them to be up on it if it's not their specialty and if they're not reading the latest research.
I do understand that. I understand it. I'm a neurologist here, and I really specialize in multiple sclerosis, aging and cognitive decline, and we're doing some Alzheimer's work, obviously, at this point. But for me, it's hard. I'm a neurologist. It's hard for me to keep up with epilepsy and Parkinson's disease. That's within my own specialty. And now I've needed to know all those GYN problems associated. Of course, I have to know those. I do. Bone, breast, skin, hair loss. Weight gain. I have to know those things just because I have to know the context for which we're getting something for the brain. I have to know the context of those other organ systems affected by menopause. But until you're really forced to do it and you do it every day and you have to think about it, doctors don't have time to learn something. Yeah. They're really busy doing what they do, and it's very hard to just pick something up that's new.
Yeah. And from a pharmacy standpoint, I still remember my compounding lab experience was not great. I knew I was not going to be a compounding pharmacist from like the first week of labs when my liquids would come back solids and my suppositories would crumble. And so that's one of the things that always frightened me about compounded products is I think of compounding pharmacies as your local tiny pharmacy, and the pharmacist behind the counter is measuring things and making things for you. And some of them are excellent. I don't want to discount what some of the compounding pharmacists can do, but on a large scale, that can be really scary for women. And, then there was an FDA kind of, I don't want to say raid, but they went out and they tested, they got prescriptions for hormones and tested them. And many of them were far too high or not even existent in their levels. And so that can kind of scare people. But because you've done the research that you've done, and from a clinical standpoint and a research standpoint, the importance of having a good quality product, you're working with specific pharmacy compounders.
That's right. I was very worried about all these, hang a shingle and start weighing it out. Yeah. I've even seen estradiol and estriol switched, and it couldn't get any worse than that, in my opinion. I'm just saying I'm very concerned about that because I know too much about the differences. And so I just said, we have to do this right, and we have to monitor it, and we have to have a standardized. And, when you go to compounding pharmacies that are so big that they're both licensed in 50 states, you've got to be able to ship across state lines. You've got a lot of regulations you've got to go through with those sort of compounding pharmacies.
Yeah, and there's a lot of restrictions.
Yeah, it's not just the local guy down the street who's doing this.
So what kind of safety measures do you guys have in place for that, for the compounding pharmacies? Absolutely.
The first thing that I do, I will say, even though I know about ER-alpha receptors in the breast, and I know about beta and not binding in the brain and not binding, I still will not treat women who've got breast cancer because the estrogens in pearl packet, the progesterones, they could still make. I'm just not going to go near breast cancer. It's just I just can't go there. I just can't because I'm very concerned about it, and we're not going to do that. So I use that same contraindication. The cardiovascular. If they've had a heart attack and a stroke, we're not going to treat them. If they got a family history, that's okay. That's not a contraindication. The clotting is an interesting one because the reason people don't give estradiol is because estradiol, when they used to be given orally, and Premarin had estradiol orally, that was another old one from 30 years ago. Those estradiols taken orally, when you take something orally, as you know, but for the audience, you get called a first pass liver effect where it goes orally into the gut and then it goes to the liver, be conjugated with something. Estradiol is conjugated to estrone. Again, estrogen's the LLA. It's conjugated to estrone, and estrone is what causes clotting. And so women that are paralyzed like MS, or people who just they're not active at all, they're not walking, they're not walking, they're up and around, and they're a clotting risk. You really have to worry about that. That's why estradiol is given as a transdermal, not as an oral anymore. What about estriol? Well, the beauty of the estriol, it's an end stage in the compounds to where it can't be conjugated to estrone. And so estrone is what causes the clotting. And that's why Europe still gives estriol orally as Menopause or Ovestin. They still do because it can't be converted to estrone by the liver.
Interesting. Because, there is so much talk on social media about how oral estrogens are bad for you. They can cause blood clots. You should have transdermal estrogen. But you just completely negated that risk with estriol.
They're talking about estradiol. They're not talking about estriol. All these statements from the old HRT studies are about estradiol. They're not about estriol.
Okay. And so again, I want to just, for the people at home who don't understand like FDA processes and stuff, if you, first of all, you're afraid of getting your prescriptions compounded by Tom, Dick, and Harry down the street. And then you find out, okay, this is a big company, but it's not FDA approved. We shouldn't do things that are FDA approved. I live on the West Coast in the Pacific Northwest, there's a lot of people who don't care because they're like, the FDA isn't all it's cracked up to be. But there are still a lot of people who are hung up on FDA processes. They want FDA approved medicines. So can you talk a little bit about that in your product?
I can, and I'm not anti-FDA approval. I'm actually all for it. I think they do a good job. I think they ensure safety. I think they're doing their best to make sure there's efficacy and there's a given indication. Estradiol is FDA approved for hot flashes, and it's got a box on it that says you shouldn't take it too long because of contraindications. And I think they're right, and I still think they're right. So I'm not against the FDA approval at all. I would love to see FDA approval of estriol So why don't we do it? We may do it. Cleopatra Rx may actually do that. If we get funding to do those trials, we will do them. The problem is an economic one. And so I have spoken with drug companies about Estriol. It's not an unknown compound. It's something we all know. It's a bioidentical. What does bioidentical mean? It's identical to the hormone made in pregnancy. It's the same chemical structure. It's not a unique thing that a chemist has synthesized with a unique group that nobody knows because it's in the patent. The patent isn't for the chemistry of it. The patent is a known chemical entity. So the problem is when you have it so widely available in compounding pharmacies in Canada, in Europe, in Asia, it's been used widely and they know what the chemistry is. All you can get is all UCLA has and that I have as the inventor. It's a use patent that says the tight dose timing with the progesterone in the blister. That's all we can get. And because of that, we'll never be able to charge $10 to $20 to $30 to $40,000 a year. We're not going to do it. I'm actually glad about it. I'm glad. I would rather make something for the masses that's relatively inexpensive as opposed to something that costs $60,000 a year for the few. It's inexpensive. It's affordable for the masses and instead of expensive for the few. So the drug companies, what they love is they love things with a chemical patent. So the chemistry is unknown. Nobody else can do it. There's nobody else can get in on this. And so they can charge an arm and a leg. And an arm and a leg, by the way, means about $40,000 to $60,000 a year. And that's how they actually pay for those trials. The phase 1, 2, 3 trials. We've been to 1, 2, 2A, and 2B. Phase 3 trials cost hundreds of millions of dollars to get FDA approval. We don't have that kind of money. And a drug company, a large big pharma, probably is not going to. Now they maybe somebody will pick up Cleopatra Rx and they'll decide or try to work with them and try to do that. That's an open thing that we could suggest. But I'm not going to change it or add a group to it just to make it so that we can charge more money. And so we can get a chemical patent on it. I'm not going to do it because we know the one we have now is safe. And we know that it works in high impact journals, NIH funded research to UCLA to do this, and publications. I'm not willing to add a group to it to make it expensive. Does that make any sense? And that's
totally.
A large pharma to go in and get something they can charge $40,000 to $60,000 a year for.
Totally. And I mean, I even remember way back in the day because a lot of these brand companies also own the generic companies. And so what people don't understand is when a brand patent runs out and the generic is available, they are able to swoop in and monopolize the generic form because they already have the compound, the structure, the testing, everything. And so they can just whip right into making the generic. And I remember, for example, Allegra, 180 milligrams was brand name, and then it went generic. And the tablets had the exact same markings on them because they literally just took the brand and they've labeled it their generic manufacturer. They didn't even have to take time to learn how to manufacture it. And so there's so many things that go on behind the scenes that people are just not aware of as far as marketing and money and those kind of things. And
the reason that but the thing is they got 21 years, and oftentimes you can get a patent extension to 21 to 25 years of a patent where they've made a ton of money.
Oh, yeah.
That supported all those trials of hundreds of millions of dollars in marketing. And then when they go off patent, they usually can't charge that much anymore. They need to go down, and they do. But you can't get them to do those large trials without that 21 to 25 year run into making a ton of money.
Yeah.
At $40,000 to $60,000 a year, you just can't get them to do it. And it's interesting with drug companies. Not only do they have to pay for the losses of that drug, I was surprised. They have to pay for the losses of the 10 to 100 drugs that didn't make it. I said, why do we have to be held to that standard? It shouldn't cost that much to even do these trials. We want to do it. And they said, but whenever we bring a drug on, we know we're going to have one winner out of, if it's preclinical research, it's going to be 1 out of 1,000 to make it. If it's going to be phase 1 or 2 trials, it's going to be only 1 out of 100 to make it. Phase 2B is going to be 1 out of 10 or 20 to make it. And for every drug that makes it, the company's got to charge for all the drugs that didn't make it. And I'm like, that is so unfair, but that's the business plan. I understand why the companies do that. But for us, we're straddled where we're harnessed with having to pay for all these failures. And we've been totally de-risked for safety, for sure, and really for efficacy with all the high impact journals.
It's kind of like the Olympics for drugs. Like they go through the whole trial process. That's insane.
Yeah.
Wow. So I'm going to kind of jump backwards a little bit. When you talked about the timing of the estrogen, or the estriol and the progesterone. What kind of progesterone is in the pack that you're using? Because we talked about the estriol, but we didn't talk about the progesterone.
So we use, progesterones are not that simple either. Some of the old data of the women's HRT studies used medroxyprogesterone. There are different types of progesterone. That's also related to the groups they have attached to them, long-acting, short-acting, and so forth. But there was some data that was concerning in the old HRT studies from 30 years ago. And I know we want to just throw them out with baby bathwater and say they were overemphasized, but you should learn. And the other thing we learned that, yes, some estradiol for too high and too long is bad, actually, for breast cancer. The other thing we learned was that when they added the progesterone on, the arm that added some progesterone on as opposed to no progesterone, because if you don't have a uterus, you don't need the progesterone. You only need to protect your uterine lining. So there were some women, a large number, that didn't need progesterone. They didn't have a uterus, but most of them did. The arm that needed the progesterone, they did a little bit worse for breast cancer than the ones that didn't need progesterone. And so we learned that progesterone, certain types can be bad. And so most everybody uses right now, it's called micronized progesterone. It's commercially available as Prometrium. Mm-hmm. And we use that too in ProPack. We load the ProPack with what's been FDA. It's actually been FDA. That is part of what's used in Cleopatra Rx. ProPack is FDA approved. The micronized progesterone it's called Prometrium. It's commercially available. We use that. It's been shown and approved by the FDA to protect the uterine lining. We still use that.
Okay, so it's the widely used and accepted form of progesterone.
I optimize, though, the dose and the timing. I minimize the dose and I minimize the timing, and I can do that because the estriol is weaker to stimulate the uterine lining to make it thick for uterine cancer as compared to estradiol. It's safer for the uterine lining as well, and so I can minimize the progesterone. There are other effects of progesterone that's too much to go into. They can have sedative effects, and I don't love that as a neurologist who studies cognition. Then again, women have trouble sleeping, and there's just a lot of trade-offs going here between safety, cognition, uterine lining, sleep, being sharp at night versus in the morning. So you can see there's a lot that goes into this protocol that we have to optimize for ProPack and cognition and most optimal safety.
So if women are listening and they're like, okay, I want to learn more about Cleopatra Rx and how this works, could you kind of give a brief rundown of how like a normal woman who says, okay, I want to try this, how they would reach out and what the process looks like?
Yeah, absolutely. They made it pretty simple. You can go to, it's called cleopatrarx.com. That's where to go, cleopatrarx.com. When you go there, you're going to see, if you want to see these papers we've been alluding to, go to our care and go to scientific publications. They'll all be there. And not all, just the top 10. But anyway, you can see it there. But if you want to go forward with treatment, so you go to the website, cleopatrarx.com, and then you go get started. What you'll do, it's interesting. You take a brain fog questionnaire that I designed, and it will ask you just 6 questions. They're very simple about, concentration, verbal memory, these things. And then from that, you can schedule an appointment with the nurse. And the nurse will call you from Cleopatra. She'll go over all the usual contraindications. She'll do the brain fog questions again, and she'll then design she'll designate you as either being a good candidate or not for getting the ProPack treatment. And it'll go to the doctor, you'll get it. And when you get it, it's shipped directly to your house.
Oh, okay. That's awesome. That's awesome.
So it's easy. Go to the website, take the brain fog questionnaire, sign up for a nurse visit, and that'll be the next step.
And then once you start, if they say yes, you're a good candidate, and you start taking it, then there's a follow-up in a few months, or how does that work? I mean, they follow up to see if you get it shipped to your house okay? Is it there? Are you starting it? And then it's usually in a few months they call, and then they're definitely going to call at 6 months, and at a year. And a year you need a refill. They ship it 3 months at a time. So for a year you'll have 4 shipments, and they ship 3 months worth at a time. They'll make in blister packs that are for a week or two. So you can, if you travel, you just take the blister pack out for that week or two, so you don't have to take the whole thing with you. Yeah, and then they'll just appear, and more often as needed, less often if people don't want to be bothered. It's tailored, That's nice. And that's nice that it's a week at a time, because I don't know how many times women would come back to the pharmacy because they left their birth control pill on the counter in the bathroom at the hotel, and now they have 3 weeks left that they can't get. And then the insurance company says it's too soon, and we have to do this whole rigmarole to get it covered again and get them on their way. So having just a week is really nice.
Yeah.
That's great. So what are you?
It's 2 weeks.
Oh, 2 weeks at a time. But still, even that's way better than a whole month.
It's nice because it's just 2 weeks at a time. So, so many people travel, they'll go for a week. So it's kind of nice to have the 2 weeks. But anyway, whatever.
Yeah. So in the field, what do you see in as far as the landscape is concerned for women's health and menopause care? And what do you see on the horizon for women?
Well, first of all, I think the horizon's bright. I think finally we have women in certain positions, whether it be, not just clinicians like neurologists seeing patients or neuroscientists like me running labs. I think it's really great to have women in journalism like you and in social media, politics. There have been women that have been very outspoken about we shouldn't ignore women's health. They're menopausal for so long. I've been on Oprah and she's been a wonderful advocate. Her menopause special, the Menopause Revolution. Also, Maria Shriver on the Today Show, the New York Times, LA Magazine. These are women really coming together to make a difference. And they're finally in a position where they can. They're 50 to 65. They said, this is happening to me. And I want it fixed. And it's not good to ignore it. I want it. And my brain is what I live. I'm living from my brain. I'm in meetings. I'm having to do complex problem solving. And this isn't going to work. I worked so long here to get here. And, I think we all hope that, the next generation, our daughters, and our just younger siblings or our sons' wives or whoever, just hopefully the next generation doesn't have to go through this like we have to just kind of try to figure out as we go. It'll be fixed. Here's a treatment that's optimized for brain. And maybe there'll be another one optimized better for bone, or maybe there'll be another one optimized better for, other things. Menopause is a multi-organ system that affects, brain, bone, breast, skin. Skin's a big one. And I do think Propac oral estradiol could help skin, the deep layers of the skin. You got to get to the deep layers. But that's something we've got dermatologists, plastic surgeons working on with Cleopatra, getting not just the superficial layers with the cream, but the deep layers as well. So there are just so many organ systems that are affected by menopause. And I hope by the time, we're down the road, we'll see that those women will have options for actually, as a scientist, a different estrogen receptor targeting this versus that. It differs by tissue type, which has more alpha or beta, or not even difference in the amount of receptors, but which receptor is more important for function in the different organs, right? You really want to focus on, this is my biggest problem, not that. That's my biggest problem, not that. And you'd like to see the whole field develop an estrogen receptor specific targeting of, what's best for breast. We've done breast and bone, but you'd like to see it really for the other things too, right? Cardiovascular and skin, bone. You really like to see all of them done, and they can be done. The roadmap is now there. Of course, the biggest thing I'm focused on, though, to tell you the truth at this point, is number one, helping these cognitive symptoms now, menopausal women now at the top of their lives, top of their careers, helping them now. But so within 12 months, they can see an improvement. But close behind that, I want to know if we can correct these cognitive issues in otherwise healthy menopausal women. Will that or will that not help delay or prevent mild cognitive impairment as a prelude to Alzheimer's disease? Alzheimer's disease is taking over every memory ward, is taking over healthcare, is predominantly women, and that's my goal.
Yeah, if there's a way to correlate that and then in turn use a solution that prevents filling up wards full of Alzheimer's-ridden women, I mean, wouldn't that be amazing?
In our lives, all the families. I mean, if you've seen it, who's not? I mean, maybe some people haven't seen it. Most of us have. And it's awful. It's who we are. Your memories, your ability to think, your personality, it's who you are. How can we not prioritize the brain? I mean, I'm biased as a neurologist, neuroscience. I know I am. But really, I mean, your brain is who you are, and we can't ignore the brain in women.
Yeah. Well, we've come so far in just recognizing that the ovaries and estrogen it's not just the ovaries. There's so much more to the body that responds to estrogen. So hopefully in the next coming, years and decades, we'll see that enhanced in, the enhanced science and research. And a lot of it's because of doctors and scientists like you that are doing this work.
Well, thank you. I appreciate that. We're trying.
Well, thank you very much for your time. And this was amazing. And I Like, I want to go and read all the articles now, but I get so excited about the science and the nuance of it. But the fact that you're taking a simple, been there for decades solution and solving a problem with it, like that's just amazing.
It's repurposing something that's safe.
Yeah.
Repurposing
Yeah, that's
something for applies in Europe because you know the receptor binding in brain versus breast.
Wow. Yeah. So thank you so much for your time and thank you for coming on. And I'll have everything in the show notes if anybody's interested in looking at Cleopatra Rx or the research that you're doing and learn more about you as well. I'll connect all that to the show notes. And my gosh, I hope this isn't the only time I get to talk to you because this has been fascinating.
Well, thanks. Anytime you want to talk, just let me know. You can email me. You've got it. Both my emails now.
Yeah, thank you.